Well, welcome. I am Michael Flaum. I am the president of the board of the American Association for Community Psychiatry. I imagine people are just joining in, so I'll speak slowly and take just a couple of minutes for introductory remarks. I'm coming to you from Iowa City, Iowa, my home. I am so pleased tonight to have the privilege of introducing my colleagues and fellow board members, Ruth Shim and Vinson, who are going to be giving a plenary on social injustice and mental health. That title should stick in your mind. That's the title of a book of theirs that is coming out, I believe, in January. I wanted to mention a few things before we get started. One is that this whole series is free. We have been fortunate enough to have some support from the Robert Wood Johnson Clinical Scholars Program. And if you go to the next slide, Ruth. I just wanted to plug that program for a minute, previous slide. Not just because they are supporting this virtual workshop, but because for those of you who may know, this is truly a wonderful program, and many of you out there, certainly many AACP members, are perfect candidates for this particular program. And I would really encourage you to click on to investigate that. Their website is on our website, AACP's. The next round of applications for these wonderful leadership development grants is in January. And I really encourage you to take a look. Actually, I see a picture. Our own Monica Taylor-Desir is pictured, I believe, in one of those. And she is the one that helped us make this connection with them. So thank you to Monica, and thank you to Robert Wood Johnson. Next slide, Ruth. I just wanted to orient folks a little bit. Many of you probably participated in our town hall that Ruth was also a part of. I can't remember, Sarah, I think you were a part of that too. And in some ways, this is a continuation of that. But it's also the first in a series of what we're thinking of as our AACP 2020 virtual forum. So as I'm sure most people know, we were very excited and we were planning our first AACP sponsored meeting in Philadelphia in October, and we had to cancel that because of the pandemic. And we are in the process of trying to transition some of that content to a virtual format. And in some ways, this is the kickoff of that, because that meeting had 6 plenary sessions, one of which was social justice and mental health. So what we are anticipating is presenting each of the remaining plenary sessions, perhaps 4 to 6 weeks apart. We don't have specific dates for the next one yet, but we will. And then, as many of you know, the model of our in-person meeting was that around these 6 major themes, we invited people to submit breakout sessions that would sort of take these major themes and look at them from a variety of perspectives like implementation, innovative and pilot programs, education and training, partnership, etc. And we had something over 80 such sessions planned. We are in the process of inviting the presenters, the submitters of those sessions, to see if they want to do virtual sessions online. And we hope to be announcing the timing of those. We don't want to overwhelm folks, but we do want to figure out a way to get this great information out to you. So that's a little background, and let me just read my chat. they are telling me that you all should use the Q&A feature. You should see a little Q&A button, and if you don't, there should be a chat button to ask questions. And I think we have Dr. Rachel Talley, who is going to be trying to man or woman the question booth. She will be coming on hopefully with about 10 or 15 minutes before the top of the hour so that we can have a Q&A period here before we get to the discussion sections, and we'll talk about the discussion sections toward the end of this hour. So I hope I didn't leave anything out. Ruth, shake your head if it's time to turn it over to you. Does that make sense? So without further ado, I would like to introduce Dr. Ruth Shim to take it from here. Ruth?
Thank you so much, Michael. And I'm just so pleased to be here with all of you tonight. Sarah, Vinson, and I are really excited to present about the work that we've been doing over the past 2 years collectively to bring all of the thoughts about social injustice and mental health together into one thoughtful conceptualization. So we have a lot of areas that we want to discuss today and not a lot of time. So we're going to fly through these slides so that we can hopefully have a really robust conversation, and then we can take that into the breakout sessions. But today we are going to be providing a little bit of an introduction to what social injustice and social justice is and how it relates to mental health. And then we are going to talk about mental health care, the child trauma system, the carceral system, substance use disorders advocacy, and then we will finish with a call to action and a discussion. So generally, I always like to ground everything I talk about in the words of James Baldwin, because he really does have a quote for everything. And the quote today that I think is most relevant is, "Ignorance allied with power is the most ferocious enemy justice can have." So John Rawls is a philosopher who defined social justice as assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. This, when you listen to this type of quote, it seems very much like social justice is something that we all can agree on is important. We all can think, okay, this is a great idea. Unfortunately, not everybody shares these views in the same way. And so last year in the Wall Street Journal, a physician by the name of Stanley Goldfarb, who was a dean at the University of Pennsylvania, penned an op-ed called "Take 2 Aspirin and Call Me by My Pronouns." And he basically was very concerned about the direction that he felt medical education was going in. He asked questions like, why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients? And he also said, curricula will increasingly focus on climate change, social inequities, gun violence, bias, and other progressive causes only tangentially related to treating illness. And so will many of your doctors in coming years. So his main thought was that these social justice warriors that are out here causing problems are straying from the true mission of what it means to be a doctor, what it means to be a physician, what it means to be a provider of health. And a group of doctors responded in their own op-ed and said that social and health policies have always determined who gets sick and who gets care and where and how. Understanding the social drivers of health and illness is not peripheral or tangential to health. It's the key to diagnosing and meeting a patient's fundamental needs. So if we're going to talk about social justice as it relates to mental health, we cannot not mention the American dream. The American dream are the ideals by which this country is founded. They were founded with this idea that if you work hard enough and if you do all the right things, you can succeed. And this myth of meritocracy has really been with us since the beginning of the founding of this country. And this country was founded on a lie. It was founded on the concept that even as we were writing that all men were created equal, or all men were created equal, in fact, the system that we created and founded this country on really elevated white males above all other groups. And what we have now in society is that even if you work really, really hard, and even if you do your very best, you don't always get to achieve that level of success. The problem is, because we have these thoughts of this American dream, most Americans believe that the reason that some people are poor, or the reason that some people have mental illness, or the reason that some people struggle in society today has to do with the fact that they're not working hard enough, that they have personal responsibility over all of these things, and they're just not applying themselves in the ways that they should. And so what we see is that that actually creates an impression of why people are healthy and why people aren't healthy. And so when we think about the definition of why there are differences in health, health disparities are differences in health status among different segments of the population, and they include differences that occur based on gender, race, or ethnicity, education or income, disability, or where you live. And if you notice with this definition, they're just saying differences in health status. And I think if you think, and if you buy into the myth of meritocracy, you can attribute all sorts of reasons to why there are differences in health status. But when we talk about health inequities, those are disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. And so when we're talking about health inequities, we're saying that those differences in health are because of our unjust social and economic policies. They are because specifically of the social injustice that exists in our society. This is a really interesting and important point because, again, many of you, if you're like me, when you were in medical school, or when you were in your training, or when you were in graduate school, or wherever you got your training, you were taught to believe, at least if you're like me, you were taught to believe that the differences that we see in health are the result of intrinsic factors between people. That some people have different cultural beliefs, some people have different values, or that some people are just genetically different or biologically different from other people. And not that the systemic, avoidable, or unjust social and economic policies were the things that were driving these differences. So this is a conceptualization of the social determinants of mental health created by myself and Michael Compton. And we don't have time to go through the whole figure, but I will just say that you can see that the many social determinants are in the middle of the screen. And they lead to poor mental health outcomes, and they most importantly lead to differences in health outcomes and differences in mental health outcomes among different populations. But today we're actually going to look at what's driving those social determinants. When we first started talking about social determinants of health, the reason that I liked that concept is because we were moving upstream. We were thinking about not just the risk factor that leads to an illness, but we were thinking about what's the thing that comes before the risk factor? What's the context that is set to create the risk factor that leads to the illness? And it made a lot of sense that you need to go further upstream in order to address these things. So settling on the social determinants of health and mental health made a lot of sense. The problem is that, as you can see with this figure, there are things that are actually further upstream than the social determinants of mental health. And those things include the laws in our society that we pass, and the social norms, the attitudes or beliefs that we have about people. Who we think are people worth value, who have value, and who do we think are people who do not have value. And all those beliefs and the laws that we pass to either support or negate those beliefs lead to unfair and unjust distribution of opportunity. And that is the social injustice that we are talking about. That is the unfair and unjust distribution of opportunity. So in fact, social injustice is the foundation by which social determinants of health and mental health are created. So if we are thinking about going further upstream than even the social determinants of mental health, we must talk about social injustice. And just to make sure that we're all on the same page in terms of some definitions, we all kind of clearly understand that inequality is when we have unequal access to opportunities. And we start to understand more that equality is when everybody gets the same thing. So equality is focused on fairness and making sure that everybody has an even distribution of what they need, the assistance that they need. Equity is actually the idea that the person gets what they specifically need to address and fix the inequity or the inequality. So the Robert Wood Johnson Foundation also uses bicycles to illustrate this point. Equality, everybody gets the same bicycle, whether they be tall, whether they be disabled. It doesn't really matter whether they're short, everybody gets the same bicycle, and obviously not everyone can ride the same type of bicycle. And equity, of course, is that you give the person the bicycle that they need so that everyone can ride together. But we will just add into this conversation and thinking about this, the importance of justice, the importance of finding places in the system to fix so that everybody has the same opportunities. So you can see that when you layer in the piece about justice, it kind of creates a different frame because the intervention becomes different. I think we could think about getting a ladder, but we could also think about how are we fixing the system in order to make these outcomes more equitable for everybody. So there's a couple of principles of social injustice that I want to talk about just very briefly. One is essentialism. That's the belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization. This is closely coupled with the concept of biological determinism, which is the false belief that racial groups are biologically and genetically different. Again, this is what I was taught in medical school, not necessarily overtly, but very covertly. And then there is erasure of context, which is when you fail to consider the socio-historical context when seeking to understand the etiology of inequities. And when we think about the erasure of context, I think one of the best examples of this is the protest psychosis and the reason why so many Black men were diagnosed with psychosis during the civil rights era. They were without context, without social historical context of what was happening in that era. That diagnosis led to overdiagnosing and misdiagnosing that still persists today. And then structural racism is a system in which public policies, institutional practices, cultural representations, and other norms work in various and often reinforcing ways to perpetuate racial group inequity. And we've discussed that at length before, so I will not continue with that. I would like to take a minute to talk about the different types of oppression. And as we go through these different types of oppression, I think it's helpful to think about your patients and the care that you provide, and think about what are the types of oppression that you have observed or seen in your own patients or that you see in your own practices. So exploitation is the unequal exchange of one's group's labors or energies for another group's advantage or advancement. Cultural imperialism is establishing the ruling class culture as the norm or othering groups that are not part of the dominant culture. Powerlessness is when oppressed groups lack power and are blocked from routes to gaining power. Perfect example of that has to do with voter suppression. Marginalization is expelling specific groups from meaningful participation in society, and we see all sorts of examples of that. And then violence are threats of experiences of either physical or structural violence. And we know that physical violence is pretty self-explanatory, but structural violence is when harm is done from social structures to people, preventing them from meeting their basic needs. So I'd like to take just a brief moment to talk about the mental health care system and social injustice as it relates to that system. We can see system inequities in healthcare in the hospital system. And that is really, has a lot to do with the way that residential segregation, revenue generation, and state policymaking comes together to create hospitals that are located in very specific areas and to create problems in access for hospital care for large groups of populations. For physicians in particular, the Flexner report is a report that lots of people cite as kind of the creation of the modern medical school. But in the creation of this report, it led to the dismantling of many schools and hospitals that serve both Black and female medical students. It led to the shutdown of those hospitals. And those students were excluded from the predominant institutions at the time. So in the shutting down of those schools, there were really no alternatives. So what you saw was lower numbers of Black people and females in medical schools as a result of the Flexner report. And then later, segregation of medical schools and anti-affirmative action policies have continued to keep the numbers of Black medical students and physicians at low rates. And then health insurance coverage is when issues with inequities with health insurance coverage include structurally racist policies advanced by the AMA and consistent efforts to dismantle the Affordable Care Act. And I'm not going to get into it because, again, we don't have time, but I will just say that the 1619 project discusses this specifically. So this is additional information for you on that. What we end up seeing as a result of all of this is that in 2018, about 69% of Black adults with any mental illness received no mental health treatment, and 42% of Black adults with serious mental illness received no treatment. 67% of Latinx adults with any mental illness received no treatment, and 44% with serious mental illness received no treatment. And for substance use disorders, it was really quite shocking. 89% of Latinx adults with substance use disorders was reported receiving no treatment, and 88% of Black adults with substance use disorders reported receiving no treatment. The interesting thing is, while you're seeing these large amounts and these high rates of not receiving any treatment, we have an insurance system that places caps on coverage by limiting the number of visits and days with cost sharing methods, benefits limits, lower reimbursements rates, and in some instances, no coverage at all, especially for substance use disorders. And what has happened as a result of this is that many psychiatrists and other mental health providers have made the decision to opt out of of private insurance networks. And so you see high rates of psychiatrists operating cash-only practices, and the proportion of mental health services that are received out of network is 3 to 5 times higher than other medical specialties. So these insurance issues end up driving people out of public and private insurance systems, setting up a system where mostly it's extremely expensive to get mental health care. It is extremely expensive to try to access the system. And a majority of our workforce is not participating in a system where people can access care. And what you end up seeing as a result is that when people with mental health problems and substance use disorders were asked why they didn't seek care, they commonly cited cost as the most common reason. And it's important to know that that's twice as often as because of minimizing their symptoms, and nearly 5 times as often as stigma being cited as the reason they did not seek care. I think we have this perception in our mind that people, especially patients of color, don't access mental health services because of stigma, or don't access mental health services because they have poor insight and they don't know that they're having a mental health crisis or a problem. And the truth of the matter is, we have created a system that makes it impossible for people to afford care. And that is the reason why people don't access services. We didn't get a chance to talk about discrimination, which also is experienced at a high rate by people who seek mental health services. And so that is just another example of why people don't get care, but not for the reasons that we traditionally think of. And now I'm just going to spend a brief moment talking about substance use disorders and moral panic in particular. So moral panic is when someone or something is perceived or defined as a threat to social norms. It can be that the news media or communities depict the threat in symbolic ways, and then widespread public concern is aroused by these portrayals. And the authorities and policymakers respond to this threat with new laws or policies, and these actions lead to social change in the community. And I think we can see that really clearly when we look at the epidemic of crack cocaine use in the 80s and early 90s, and the way that moral panic descended on the idea of crack babies and crack mothers, and this thought that these women, typically Black women, were harming their children that was not supported in the data, and that there was basically kind of a panic around how dangerous crack cocaine use was. to the point that crack cocaine ended up being sentenced at a disparity of 100 to 1. That disparity was changed in 2010 to 18 to 1. What's really disturbing about this is that these are the same drug, and the disparity still exists today. And how that affects mental health care and the way that we deliver substance use disorders was mentioned by Ernest Drucker in A Plague of Prisons. The fundamental clinical accountability of drug treatment professionals to individual patients has been subordinated to the goals of the criminal justice system. And then the other thing that we often see with substance use disorders is this juxtaposition of the way we think about the opioid epidemic as a public health crisis and the way that we think about the crack epidemic as a criminal justice crisis. And we continue to do that in our policies and our practices today. And this work has been really clearly described by Julie Netherland and Helena Hansen. And so now I'm going to kick it over to Sarah.
All right, can you hear me? Looks like a yes. That transition wasn't too bad. So I will be talking about child trauma to start, and then a little bit about the criminal justice system and advocacy. So this is a quotation from Trauma and Recovery, the text by Dr. Judith Herman, that says, "The developing child's positive sense of self depends on the caregiver's benign use of power." And as adults in a society where kids don't get to vote and where adultism runs rampant, I would encourage you all to think about that caregiver not just being parents, but also being systems that are entrusted with children's lives. So the education system, the foster care system, and these various places that make really significant choices about where children live, where they learn, and where they play and where they grow up and develop. And these are three quotations from patients, or people, I should say, that I saw in different contexts that illustrate how important context of where people grow up is. So one was an adult defendant that I met in my work as a forensic psychiatrist in a capital murder case. And he said, "I was proud to make it to 21, even though I was in prison." One was a white male I saw in my private practice clinic who said school was all I ever really had to worry about, who was coming in because of a concern about ADHD. And the third was a detained teenager who said, "They say I'm supposed to care about people when ain't nobody cared for me." And that first person, we'll call him Miguel for the case, for the sake of this presentation, we'll come back to his story. And so there are things that we know children need in order to have healthy development, both physically and mentally. And this is not new to anyone. And we all know that these are basic necessities. So one would be a true home where they have stability, food security, and their basic needs met. Another would be a reliable caregiver that's a consistent, available adult, and that this is essential for instilling a sense of worth and having an advocate for that child. Educational opportunity to include safe schools, a school that prepares them for career or college, and also has special education resources available when they're needed. And healthcare, medical care, mental health care, and to have both adequate care and access to that care. So knowing that that is what children in this country or any country need, we allow children to live in poverty. And it's interesting when you're looking for stock photos of child poverty, so many of them are from different countries and not from the United States. But 1 out of 5 US children live in poverty, and that's a number of 15 million developing brains. And that threshold is set at $26,200 for a family of 4. So as you can imagine, there are a lot of people who don't quite live in poverty, but who can't meet basic needs. 43% of US children live in low-income families. And again, sort of contrary to the popular narrative, while it is true that a higher proportion of Black and Brown and Native American children are in poverty, the majority of impoverished children in this country are white. And to think about the choices that our country makes and who is making those choices. We allow 1 in 5 children to live in poverty in a country that spends $732 billion on defense in a single year, which is more than the next 10 countries combined. In a country where the majority of US lawmakers are millionaires and 76.8% are men. And I point out those last two things. Brian Stevenson talks about how there needs to be some proximity to pain for the people who are supposedly coming up with solutions for it. And we have a disconnect between the experiences of families and children and the people who are drafting those laws and the people who are deciding how those laws are interpreted. And I point out that 76.8% are men because the issue of parity when it comes to women's pay and childcare are central to meeting these needs. And so when you have poverty, if we go back to those things that we know people need, it undermines every single one of them. So it can be hard to have a true home, and that leads to housing instability, food insecurity, and then there's a higher risk of exposure to heavily policed neighborhoods. Impaired caregivers, you often have situations of multi-generational trauma where poverty has impacted multiple people in a family. And it's hard for adults, if not impossible for them, to give children what they themselves do not have. So when they are poorly supported, they can't provide that support to their children. A lack of living wages, and they may have unavailability because of mental illness, incarceration, or work. You also see that these same communities are dealing with unmet educational needs and have under-resourced schools. And with these schools being under-resourced, children aren't able to use the educational system to climb their way out. So rather than seeing a system that allows them to transform their lives, it merely replicates the current social hierarchies. And then if they need mental health care or they need medical health care, there's limited access because there's both gaps in coverage and capacity. When mental illness is present and it's not addressed, you have an impact on school attendance and their behavior in a society that may have less, may allow them less leeway for acting in different ways. So to go back to Miguel, who said, I was proud to make it to 21, even though I was in prison. I met him when he was in his mid-30s, facing the death penalty for a robbery that had gone wrong. But he was somebody who had been incarcerated from the age of 17 to 21. And he was put in prison after the violation of his probation plan because he was found in possession of marijuana. And his original charge was not a violent offense. And this is what his environment looked like as he was growing up. So he was in a state that had low mental health spending, 48th or 49th per capita. He was placed in a child welfare system that was grossly understaffed. And it was at a time when there was a really punitive stance toward adolescents and this narrative around super predator youth. He ended up in 12 different foster care placements. So you have this system that's supposed to be a child protective system that is supposed to be taking care of him and not providing him with the basic need of stability. And he had unmet educational needs for his learning disabilities and unmet mental health needs as well. He was exposed to chronic poverty in violent neighborhoods where he had housing and food instability before he went into the DFACS system and was victimized by both his peers and his brother. And family dysfunction. His mother, who was herself a victim of childhood sexual abuse, abandoned him, and she had untreated trauma and substance use disorders. His father had been incarcerated on a nonviolent drug offense, and he was abused by his grandmother and brother, and also saw his mother abused. So his case was one where, yes, he was facing this charge, but when you look back at his life, it was clear that there was multi-system failure. And because of those unmet needs, he was at higher risk for juvenile justice system involvement. And so when we're thinking about trauma, structural trauma, the education system didn't set him up to have a different life. The DFACS system didn't give him the stability to even dream of what that would look like. And he quite predictably ended up in the system that always has its doors open. So he had a foreshortened sense of future. And because of that, he couldn't really invest in this idea of preparing for a future that he wasn't convinced that he was going to have. He had a negative attitude towards school because it wasn't a place where he learned. It was a place where he got into trouble. It was a place where he was ridiculed because he was poor. It was a place where people focused on his behaviors without understanding his environment. And he had this resignation to justice system involvement because that was what he had seen in his older brothers. There's poor problem behaviors in the family, poor supervision, poor attachment to them, and sibling antisocial behavior. And his sense of safety had been undermined throughout his life, to the point where there were things that he experienced in his life that he didn't even register as traumatic because this was just how he had experienced growing up. And of course, his physiological needs weren't met either, with the poverty, community instability, the crime, and the availability of firearms, and his early exposures to seeing people harmed, sometimes fatally. So what this does is set the stage for overrepresentation for youth with mental illness in the justice system. If you look at the kids who end up in juvenile justice, 70% have mental illness and 30% have serious mental illness. So how does this get back to trauma? One of the things that I see as a forensic psychiatrist is that you have people with stories like Miguel, and their chart says things like oppositional defiant disorder and conduct disorder. Often there is no acknowledgement of what they have experienced, of the traumas they have gone through, or of any indication that the evaluating mental health clinician has considered what this instability and community violence and structural violence has done to this developing brain. Part of it lies with us, and part of it lies with how our very diagnostic criteria is set up and in the instruments that we use. So an example is criteria A for PTSD doesn't acknowledge a lot of the things that kids like Miguel experience in terms of structural trauma as a qualifying criteria. Another example is the ACE score. And of course, there have been subsequent studies since that first one that look at things like racism and community violence. But what I see also on the criminal justice side is that that original 10-question scale, which was normed on middle-class white people in Northern California, is often the one that's used. And it doesn't take into account a lot of the traumas that these children experience. And so there's a way that we can be bystanders in traumas that don't affect middle-class people, traumas that are disproportionately impacting the most marginalized members of our communities. And then to transition into the criminal justice system, when we put things like ODD and conduct disorder in charts and fail to recognize this trauma and fail to help people understand what this child needs or give them what they need, in some ways we become perpetrators. We contribute to the narrative of this child being bad, of this person being irredeemable, and we contribute to the society's pattern of not protecting them and not acting as if they're worthy of care. I have seen this in forensic work, and we see this in the charts that we review, that the lens that is used to understand their behavior often doesn't take the broader context into account, often doesn't think about that broken American dream, and is quite arbitrary in who it criminalizes. So I have criminal justice system in quotes because we know that in this country, criminal behavior is much more evenly distributed than you would think based on who gets convicted and who goes to jail, that we are arbitrary in who we criminalize, with the issue of illicit drugs being one of the main ones, that we know that people of different races use drugs at similar rates, but not everyone is going to jail for it at the same rate. And justice, the system is demonstrably unjust, and we'll talk a little bit about how that is. This is a video of a young Black boy who was playing basketball, who saw the police come by and decided to hide behind a car because he was afraid. And if you haven't seen it, it went viral, so many of you probably have, but it just points to how going through everyday life, you always have to be vigilant as a Black person in this country. You're always at risk of being interrupted because of the realities of racism. So with our system, it's really not a matter of a few bad apples. It's not a matter of a few police officers that get it wrong. It's a system that consistently creates racially unjust results. And to their credit, most judges acknowledge that the system is racist. So this isn't just about a few bad cops. This is about a racist system. 80% of state judges are white. And I point this out because, as Dr. Shim alluded to earlier, so much of the social determinants is driven by policies and by our laws. And so when 80% of the people interpreting these laws are of one color, it's going to affect how that's applied. And what we see in this system is that there are sentencing outcomes that are different, not only by race, but also by how dark-skinned or light-skinned someone is, so also by shade. And that's after you account for the kind of crime and someone's legal history. And so in thinking about how this ties in and fits together with structural violence, there was a widely shared video of the Secretary of Education talking to a journalist about schools in Michigan. And I wanted to use this as an example because this is someone who is responsible for setting national policy as it relates to education. And what happened in Michigan is that charter schools were given a wide berth, and money that should have gone to public schools was reallocated. And you had these school buildings that were supposed to hold a certain number of students that now have fewer students. And it led to funding issues and to resources not being adequate for the kids who remained in those traditional schools. And so Detroit is the major city there, and the graduation rate for Black males in Detroit city schools is 23%. So only 23% graduate high school. And what we know in this country is that when a Black man doesn't graduate high school, he has a 60% chance of becoming involved with the carceral system. So thinking about advocacy, and in a nod to B.B. Moore Campbell, your advocacy ain't like mine. One of the questions that we got before this session was, what can we do? What's the one thing that all of us should do as it relates to this? And the answer is, it's not dependent on someone else dictating to you what that one thing is. It's really a matter of you using what you're passionate about, what your gifts are, where your place is to advocate in a way that resonates with you. And on this slide, I have people who have been inspirations to me and who have advocated in very different ways. So on the top right is Dr. Joe Bona, who was a psychiatrist here in Atlanta, who, as you can see, was a white man, but was an incredible mentor to many Black women, including myself, but a real leader when it came to state advocacy, policy, public sector psych in Georgia. You also see a picture of the book Trauma and Recovery, which was written by Dr. Judith Herman. And this book was absolutely a form of advocacy because it spoke to the issue of traumatized children. It spoke to the issue of familial incest at a time when people weren't discussing this and where this wasn't front and center. And we still see that complex trauma isn't recognized by our field in the way that it should be. So the advocacy continues. And in the bottom left, you see a snapshot of the Morehouse School of Medicine Child and Adolescent Psychiatry website. And I use this as an example of educational advocacy. And so while this is the first child psychiatry fellowship at an HBCU medical school, the two people that I would say were most instrumental in helping us pull that off were our program coordinator and Dr. Arden Dingle, our program coordinator, Tiffany Burns, and Dr. Arden Dingle, who's a white woman who was on the West Coast, who was an incredible sponsor and mentor to me. And of course, bottom center, Dr. Anel Prim, who has been an advocate in so many different ways through the APA, through the Steve Fund, through community leadership, through the All Health Alliance, who has really been a generational mentor for underrepresented minority doctors. And so 3 steps to advocacy. The first would be developing a knowledge base, and this has to do both with who you are and how you operate and what your knowledge deficits are, but also in understanding the needs of your community and who your natural partners would be. Recognize injustice and your role in addressing it, and understanding that that role may change over time, and respond to injustice through an iterative, sustainable process. So with our call to action, I want to go to Raymond Santana. So he was one of the formerly known as the Central Park Five, now known as the Exonerated Five. He was incarcerated at the age of 14 after a false confession. He was incarcerated for 7 years. And after he was exonerated, it took another 12 years for the settlement to occur. And I had the privilege of being able to interview him a few months ago. And we had that same question about what should we do to address these issues? And his reply was, we need all hands on deck. So this isn't something where everybody needs to go off and decide to run for office or go get another degree, but wherever you are, there is injustice, and wherever you are, there are opportunities for you to do things to address it. So start where you are, use what you have, and do what you can.
So I'm just going to go through 4 steps of how to begin to take action. Step 1 is education and self-reflection. There is a lot of personal work that has to be done in order to start to move in this space. And we're going to talk in just a second about how to begin that process of education and self-reflection. And then Frantz Fanon said that we need different models, schemas, and examples that are different from our European psychiatric perspective. And so I think we in the mental health field need to consider different models, schemas, and examples and be open to considering those. We need to transform the way that we teach, the way that we teach students, the way that we teach trainees in all fields in mental health. And we need to re-examine research policies and clinical practices.
And coming soon, shameless plug, the Social Injustice and Mental Health book edited by Ruth Shim and Sarah Vinson, that's us. But a couple of reasons we wanted to point this out is this is our author list, and it is a majority minority author list in terms of the people that were involved in writing our chapters that produced the content for this book. And we wanted to write about this issue, but we also wanted the book to be an example and a rebuttal of some of the things that we hear in medicine, where people say, well, there aren't qualified minority people to do insert here. This book is a testament to the fact that excellent work can come out of minority people. And it is also a testament to interdisciplinary approaches. So we have psychiatrists, social workers, lawyers, teachers who all contributed to it. And it will come out in January 2021. And we have dedicated it to Carl C. Bell, who we believe is the quintessential social justice psychiatrist.
So when we're thinking about these topics and we're talking about social justice, there's not an option not to be political when we talk about these things. Political stances and policy interventions are required. So to remain apolitical or neutral is actually its own political stance. That is a tacit acceptance of the status quo. So that is not an option for us anymore. I think that's what we've been doing. That's the mode we've been operating in. We cannot be neutral. We cannot be apolitical. And the last thing, because when we start to make progress, we need to be prepared for what happens when progress gets made. So if we think that we can make change through new models, through new schemas, new examples in psychiatric training, patient care, research, and administration, and I think that we will, and we will do this, at the same time, we must accept that there will be retrenchment. And retrenchment refers to the ways in which this progress and the people who champion this progress is very often challenged, neutralized, or undermined. And so when progress is made, if you are not expecting the retrenchment, you may start to give up, you may become hopeless. And so it is really important, and we've seen so many examples of this bear out in society, it's really important to be prepared for the retrenchment that inevitably comes. And I think that John Lewis said it better than anyone when he said, do not get lost in a sea of despair, be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is the struggle of a lifetime. Never ever be afraid to make some noise and get in good trouble, necessary trouble. So thank you, and we'll take some time for questions now.
All right. Well, first, I mean, I'm sure I speak for everybody in thanking the two of you so much. I'm sorry, Michael, were you going to jump in first before questions? I figured I'd dive right into it since we just have a couple of minutes left. So first, thank you. And I know I learned a great deal from this talk, and I'm sure many of us agree with that, whether it's, I learned new things about the ACEs study, as well as the percentage of folks of color who are not receiving treatment. I was staggered, frankly, by those numbers. I'm gonna pull first a question from Amit, who posed, basically wanted to ask a little bit more about how our formulations in residency, so the education, the way determinants of health and social justice, and that many of these elements are absent or oversimplified. And so the question was, what are our next steps concretely in terms of increasing the adoption of factors perpetuating social justice in our formulations in our field, and then bringing those formulations into spaces where these inclusions could have tremendous impact. So, the criminal justice system, which has been brought up, public education, and then reframing how the public thinks about treating mental illness.
I'm going to let Sarah take that. That's
All right.
a great question and a hard one. So I'm going to let Sarah take that.
I think that work is underway already, because, and it's really coming from a lot of our members in training and our residents that are pushing a conversation that looks different, that asks about things like racial violence and community trauma. And we need you all to continue to do that. Our diagnostic system still doesn't do that. And so this points to the need for us to really have that in our formulations, and to the need for us to do a lot of education outside of our own field about what it means when someone doesn't get a PTSD diagnosis, how trauma can still be impacting them and still be influencing their behavior, their thought, their decision making, even though they don't quite meet criteria for PTSD. And there is work to be done in that space, certainly in the educational system, the criminal legal system, but I think there's work that we need to do in our field and get the criteria right, and do things like recognize diagnoses like complex PTSD rather than calling kids DMDD, ODD, CD, all of these diagnoses that don't acknowledge their trauma at all.
Right, those diagnoses that are erasure of context, that create diagnoses that have no concept of the context by which these issues come into play. So I totally agree. I do feel optimistic, just like Sarah. I do think this work is being done. How to get, we're in, I think, an early adopter phase. And I think that we need to figure out a way to start to bring more people to this work. And I think that the more people who have an understanding of this, the greater it will begin to spread. And I think we are moving in a positive direction in that way. And I agree with Sarah that our trainees and our medical students are 100% leading the way on this. The medical students at UC Davis have pushed this agenda. They've held our faculty accountable. They've asked them questions. When they present data around disparities, they ask, what is the cause of these inequities that you're describing, and give us good reasons for that. And they're not just accepting. I mean, I had to sit in my medical school classes and just kind of listen with with kind of incredulity. But our students now are not accepting of that. So I think we are moving in the right direction.
Cause for optimism, right? I'm thinking we're at 8:55, maybe squeeze in at least one more question. I guess I'm curious, thinking something that you brought up that was really striking to me was these very notable percentages as far as folks of color who aren't getting access to treatment, both individuals with serious mental illness and individuals with common mental disorders. And you highlighted some of the barriers in insurance as far as access that are relevant there. I'm wondering, particularly because we are an audience of community psychiatrists working with underserved folks, if you guys could comment on some of the other sort of on the ground barriers that you think are most important as far as why these patients aren't seeking or getting access to treatment.
Yeah, and I would just say a big one for me is discrimination, is mistreatment of people when they go to seek services. And you know, we talk a lot about cultural competence, but you know, 2% of psychiatrists in this country are African American. And so when you see those numbers of patients, of Black patients who have mental health problems, who aren't necessarily accessing those services in those settings, I think when people do go and access treatment, they are often facing providers that either don't look like them or have very different experiences from them, providers who often come from a place of privilege. And I think sometimes we don't really even, we didn't get a chance to talk about how medical schooling is such that as time has gone on, people who are richer, more people who are richer are going to medical school. So the level of debt is actually decreasing over time. And it's not because we're getting better at paying for medical school. It's that the people that are going to medical school aren't amassing debt when they go because they're able to pay for it. And so if you have a completely different experience from somebody, they don't look like you, they don't come from the same socioeconomic background, you maybe have lived your entire life without interacting with anyone like that, you may treat them in a very different way than you would treat somebody who looks like you or who you consider to be someone who reminds you of a family member or a friend. And so I think what happens is, and we have data to support this, when people of color or LGBTQ people, when people go and access services, they're often treated horribly. And one time may be enough for somebody to have a one-time interaction and say, I don't really need to come back here. And then what happens is the illness becomes much more severe over time, and then people end up accessing these services in emergency settings against their will. And the data supports this as well. We know that people of color are more likely to access acute services rather than outpatient services.
And one more thing I would add to that is just the structural trauma aspect of it. So in order to engage with a system, there has to be a belief that the system's going to help you. But when, and it was, as we wrote this book, so the book was originally supposed to be social justice and mental health. And as we just saw injustice after injustice in every single system, we couldn't name it that anymore. And so if you're from a population that has been othered, marginalized, poorly served in education, housing, DFACS, criminal justice, DJJ, you know, the idea that the mental health system is going to be the one that knocks it out the park may be hard for people to wrap their heads around.
Absolutely. I'm going to kick it back to Michael because I know we're almost out of time.
Okay.
And I know there's a question about slides being available after. So.
Yes. Ruth is shaking her head. We've recorded this. The recording will be on our website, hopefully within the next day or two. And I assume the slides will be available?
Yeah.
That's a yes. Okay. Okay. All right. So we're going to transition to the discussion group, but just I want to just take a moment to thank you both. About an hour before this started, I read John Lewis's piece, which I would recommend to everybody. He wrote it less than 2 weeks ago to be read at his funeral. And I think it's widely available. But in it, he says, "You inspired me." And I'm just going to, he said, you filled me with hope about the next chapter of the great American story when you used your power to make a difference in our society. And he goes on, but he's talking about being inspired by what he's seeing. So thank you for inspiring me on this day, on this special day. And I look forward to having an opportunity to kind of process this. I'm feeling personally a little bit overwhelmed right now, to tell you the truth. But we have these groups, and they are on the chat. The links are on the chat. So as you can see, there's a group, and you can go to any group that you want. It doesn't matter what group you signed up for. We just want to have a place where people can talk. This will not be recorded, the discussion. So there's a link for educators and researchers. There's a link for clinician leader administrators. There's a link for members in training, and there's a link for early career psychiatrists. Each of those will be moderated by 2 people. I won't go through it now, you'll see. Join us at AACP if you're not already a member. We need you, we want you. And thank you again. We're gonna have to leave this meeting and then go to the other links. I think you can, I don't know if you can actually click on a link before you leave. I don't know what's gonna happen, but I'm gonna try that. Okay, so thank you again. Good night, and I hope to see some of you on the other end.